Good morning, everyone. Diuretic resistance, though we often use it very commonly, there is no fixed definition. Failure to achieve adequate decongestion despite appropriate dose of diuretics, clinically persistent fluid overload, weight gain, edema, and congestion, they often requires combination strategies or advanced therapies. It is associated with poor outcome and higher mortality. It is basically a sign of underlying severe heart disease, advanced heart disease, often associated with renal failure. These patients often require repeated hospitalizations, and a patient who is discharged with residual congestion is bound to come back within short time. It increases the healthcare burdens, and it reflects the progression of underlying heart failure. There are some definitions in the literature. Most importantly, one has to identify them qualitatively: persistent congestion, clinical, radiographic, biomarker, and despite maximum ceiling dose of loop diuretics. The quantitatively, some people have defined in different clinical trials. Oral furosemide 160 milligrams twice daily or equivalent fails to increase sodium excretion more than 90 millimoles over 3 days. Spot urine sodium less than 50 to 70 millimoles per liter at 1 to 2 hours after loop diuretics, and urine output less than 150 ml per hour in first 6 hours after IV diuretic also. IV diuretic is used. These are some of the definitions. Alternately, one can look at the fractional excretion of the sodium, that is less than 0.2 to 1%, indicates resistance. And as I mentioned, there is no universally accepted metric. What are the common causes of resistance? The incorrect diagnosis: patient may be having edema due to other causes. Non-adherence to recommended sodium and/or fluid restriction is very common in some individuals, especially from India. They take a lot of salt. Drug not reaching the kidneys, either because the patient is not taking the drug, or the doses are too low or too infrequent, and patient for some reason, especially with heart failure, gut edema, may be having poor absorption. And reduced diuretic secretion: tubular uptake may be impaired by competing uremic toxins. There may be decreased renal blood flow, or functioning kidney mass is low, as in renal failure. Insufficient kidney response to drug may be seen because of the low GFR, decreased intravascular volume despite elevated total extravalvular volume, people with pleural effusions, ascites, etc. Activation of the renin-angiotensin system is a compensatory mechanism, and nephrons also adapt to prevent the sodium loss. And use of non-steroidal anti-inflammatory drugs is very common cause in our setting, where patients may come back with fluid overload. What is the pathophysiology? There can be pharmacokinetic factors, as I mentioned, about absorption, bioavailability, renal drug delivery. Pharmacodynamic factors like renal adaptation, nephron hypertrophy, tubular intolerance. Neurohumoral activation: heart failure is perceived as a threat for maintenance of blood pressure, and body physiologically calls forth renin-angiotensin system, sympathetic nervous system, and arginine vasopressin system. All of them lead to fluid overload. That is how the body tends to maintain the blood pressure. And there may be compensatory mechanisms: alter the sodium-water the handling down the nephron, and multiple comorbid conditions like CKD, diabetes worsen. One can see after 6 weeks of the diuretic, 6 days of furosemide infusion, the distal tubular cells they develop hypertrophy, and they start reabsorbing the sodium much more. This is a compensatory mechanism. How do we mitigate various mechanisms responsible for diuretic resistance? If the patient has malabsorption and increased, sorry, the slides are not good. Sorry about it. Malabsorption and increased abdominal pressure, use intravenous diuretics, or sometimes you have to do paracentesis of the abdomen. The ceiling dose, increase the dose of loop diuretics. We'll come back to it again. Compensatory post-diuretic sodium reabsorption will be there, so that patients have to be given frequent doses of diuretics, loop diuretics. Breaking phenomena, as I mentioned, the distal tubular cell hypertrophy may be there. The adding thiazides may help there. Neurohumoral activation, sympathetic activation, we give the standard treatment with the beta blockers and ACE inhibitors. Then intra-extravascular leakage: because of the Starling forces, there can be fluid or fluid loss into this one extracellular volume, extracellular space, and actually hypovolemia they may be there in these patients. These patients may better benefit with hypertonic saline. And reduced renal perfusion: consider vasodilators, inotropes, and kidney failure is there. Increase the dose of loop diuretics and ultrafiltration or dialysis. This is the dose response curve for loop diuretics. On the x-axis, you see the logarithmic with each increase in the logarithmic scale of micromoles per ml. There is a steep curve for the fractional excretion of the sodium. At one point, it reaches the ceiling. Beyond that, it doesn't work. In patients with heart failure, the sigmoid-shaped curve, loop diuretic efficacy curve, is shifted down and right. It decreases because of the decreased secretion to the tubular lumen, tubular resistance, and increased reabsorption in the distal tubules. And also because of this, there is a flattening of the ascending curve of the sigmoid-shaped curve, and also ceiling is low. So one has to be careful. One has to keep it in mind in this one. The standard recommended doses for the people who are not previously on loop diuretics, you can start with 20 to 40 milligrams, and our ACC expert consensus is 40 to 80 milligrams. Patients who are already on loop diuretics and come with fluid overload, one can increase the IV dose to 1 to 2 times or 2.5 times. And the loop Lasix, you know, that's a common word. That is, it works for only 6 hours, and in the maximum action is in the first 2 hours. You see the very steep fall in the sodium loss in these patients. Now, what are the ways to understand whether the patient is having appropriate response to loop diuretics? There are the following metrics can be used. Spot urine sodium, 1 to 2 hours post-diuretic, it should be less than 70 to 80 millimoles per liter. That shows that the inadequate response is there. Similarly, 6 hours cumulative urine loss, if it is less than 90 millimoles per liter. Urine output is less than 150 ml per hour. Fractional excretion less than 0.2 to 1%. Weight change to less than 2.7 kgs. These are all signs of incomplete, inappropriate or inadequate diuretic action. That you can call them diuretic resistance. Now, here you can see sometimes diuretics in the upper diagram you see there is a good adequate diuretic response, and in patients with diuretic failure there is no response, or it may be a short response for a very short while. So if it is a short response, one can increase the frequency, and if it is a inadequate response, or you can use a continuous drip. If it is a diuretic resistance is there and the response to diuretics is very minimal, one has to increasing frequency doesn't help, and one has to increase the dose. And this may occur with, as mentioned, various other factors, commonly with increased GFR and proteinuria patients, CKD patients, and one has to increase to the maximum extent. This is the 2021 ESC heart failure guidelines. When the patient comes with decompensated heart failure and with acute congestion, as I mentioned, you start with, if the patient is drug naive, you start with 20 to 40 milligrams of intravenous furosemide. If patient has been taking diuretics at home, make it 2 to 2.5 times more and give our intravenous, and follow the urine output, whether the patient is making enough urine of good quality with good loss of sodium. And if it doesn't occur, one can repeat the dose. That way one can go up to a maximum ceiling dose of 400 to 600 milligrams of furosemide or equivalent over 24 hours. But frankly, I don't know, probably my maximum experience about 200 milligrams. I don't think I ever exceeded that much intravenous Lasix furosemide in these patients. So if the patient has achieved more than 3 to 4 liters in the first 24 hours, you continue the current management, taking into consideration the other clinical factors, and simultaneously optimize the GDMT and early initiation of SGLT2 inhibitors, MRA, etc. If the patient reaches the ceiling dose and also still doesn't have benefit, one can combine the diuretics, first line thiazide diuretics, second line esgelamide or SGLT2 inhibitors, third line vasopressin antagonists, and inotropes if cardiac output is suspected, low cardiac output is suspected. Of course, there can be debate on these things with the recent knowledge that we have. And there is a feeling that continuous intravenous furosemide infusion is beneficial in these patients. There are 2 trials or more trials. The Flecker et al. In New England Journal of Medicine 2011, there is not much difference whether a patient received bolus or intermittent bolus or continuous infusion. And another paper in 2014 there is actually more events in the patients who received continuous infusion. So probably there is probably worsened outcomes if one gives continuous high dose diuretic infusion. The patient diuretic infusion in resistance can be predicted based on the BAN ADHF risk score, which takes into consideration the blood urine nitrogen, creatinine, NT-proBNP, atrial fibrillation, hypertension history, and previous heart failure admissions. The sequential nephron blockade, as I mentioned, there are what I call there is diuretic resistance in the loop diuretics, and the compensatory mechanisms will be there. The sodium absorption occurs in the proximal convoluted tubule, loop of Henle, and in the distal convoluted tubule as well as the collecting ducts. And actually, most of the sodium reabsorption occurs in the proximal convoluted tubules, and only 20-25% in the loop of Henle. And in the proximal convoluted tubule, using the SGLT2 and acetazolamide, one can prevent the sodium reabsorption. Thiazide diuretics, as you know, work in the distal convoluted tubule, and collecting ducts, vasopressin receptor antagonists may be helpful. There are the various trials which focused on where the action is. I'll be discussing some of them. The chlorotic trial where they used hydrochlorothiazide with furosemide, there is greater weight loss, but at the cost of increased creatinine and hypokalemia. Metlozone trials and metlozone and furosemide, again synergistic action, but again hypokalemia or hyponatremia in our setting is very common. And in propensity analysis by Briscoe, Back et al., the metazoline versus higher loop diuretics, uptitration may be as effective as early thiazides in these patients. In a comparative trial of diuretics, metlozone, chlorothiazide, and tolvaptan, there is not much of difference between the three different agents. The acetazolamide was tried in ADVAR trial, and it is shown to be effective when intravenous acetazolamide was given. Patient successful decongestion was achieved by 3 days in these patients with better congestion scores and successful discharge. The mineralocorticoid antagonists are standard in GDMT. They decrease the sodium absorption in the collecting tubule, and there is no point giving higher dose of spironolactone. 25 milligrams is good enough. By increasing the spironolactone dose as shown in Ethanol trial, there is no benefit. And role of SGLT2 inhibitors, apart from the diuretic action, there is multiple other benefits. Because of that, we use routinely in the heart failure patients. As a matter of testing for diuretic resistance, the dapagliflozin study showed there is not much difference between metlozone and dapagliflozin. The vaptans can be used because they are ADH receptor antagonists, and the diuresis is prevented. Everest study has not shown any clinical benefit in outcomes. However, they are drugs of choice useful in patients who are having dilutional hyponatremia. So the sequential nephron blockade strategies include optimize the loop diuretics, add thiazides, add MRA, acetazolamide, and vaptans. But as I mentioned, all of them have got important side effects, and the frequent monitoring of electrolytes and urea, creatinine, acid-base balance has to be monitored. Now, the efficacy of loop escalation is moderate. When you add thiazides, there is a weight loss is maximum. And if you add acetazolamide, it is a moderate increase in weight loss. And SGLT2 inhibitors are also moderate. Ultrafiltration has highest weight loss, and vaptans are also modest. But as I mentioned, there are a lot of side effects. The accompanying adjuncts, sometimes albumin, hypertonic saline, and dopamine can be used. Dopamine is not shown to be, except for the very initial small study. The ROSA trial did not show any benefit, so there is no point giving low-dose dopamine. And albumin infusion can be tried along with IV diuretics if the patient has severe hypoalbuminemia with albumin less than 2.5 grams. Hypertonic saline, as I mentioned, there can be a severe extravascular volume overload. In those patients, cautiously, one can give hypertonic saline along with the diuretics to cause maximum diuresis. The non-pharmacological removal includes ultrafiltration and peritoneal dialysis. Their rapid isotonic plasma volume removal will be there. They can remove more sodium per liter. Ultrafiltration is very effective for severe refractory congestion. The risks include access site complications, hemoconcentration, hypotension. And very Rarely a patient may be considered for peritoneal dialysis, but in the overall scheme of things, it doesn't make any change in the outcomes. In the unload trial, studied over 90 days, the ultrafiltration arm has lesser events compared to the standard care arm. In the KRS heart failure study, which was published in 2012, paradoxically, the weight loss is not much, and serum creatinine is slightly more in these patients with ultrafiltration. So overall, ultrafiltration is to be reserved for a very unusual patient who is not responding to diuretics, and we have got refractory fluid overload. So what are the clinical guidelines? The guideline direct approach, loop diuretics at adequate dose and frequency, escalate the dose as needed. If inadequate dose, after checking the urine sodium excretion and the volume of urine, one can add MRAs, SGLT2 inhibitors for all eligible patients. Use Vaptans for hyponatremia, not corrected with other strategies. Ongoing assessment of renal function, electrolytes, and congestion state is very important. The non-pharmacological interventions include cardiomemes and bioimpedance-based approaches. They are useful in identifying early identification of the fluid load and increased filling pressures, and the appropriate treatment, early treatment can be very useful. The key is that the parameters have to be identified and appropriate action should be taken immediately. Yesterday, Dr. Witt was talking about the telemedicine and remote monitoring. The intense monitoring, as is shown in the German study, unless it is done, there is not much use just in monitoring. A multidisciplinary team has to be there, and home monitoring of high-risk patients can be done, and there should be a structured telehealth intervention, and then it can make some difference in the hospitalization rates and probably in mortality. But such a rigorous approach may not be possible. Probably in future, AI helped algorithms may be helping in these patients. Self-monitoring and the patient education are very important. Can you see this? I don't know. I'm sorry, the quality of the slides is poor. So basically, it says the same thing, that 90% of the patients are helped with the diuretics, routine diuretics, loop diuretics, and in 10% where there is a refractory diuretic resistance, one can use thiazide diuretics. In this context, the BAN ADHF scores and Frisomet stress test can be done. And all patients, before considering diuretic resistance, should be on the standard therapy, including SGLT2 inhibitors, MRA, and ARNI. And it's important to monitor the congestion in these patients by congestion scores and simple clinical examination, weight, body weight monitoring, and lung ultrasound. And of course, the biomarkers like NT-proBNP will be helpful. The emerging future strategies include novel agents targeting different nephron segments like pendrin inhibitors, integration of the point-of-care imaging like lung ultrasound, IVC assessment, biomarker measurement, and monitoring urine sodium. Of course, the urine sodium excretion is very much influenced by the sodium intake, but if only we can monitor the urine sodium regularly in a patient with a standard diet, probably we can pick up early fluid retention. Precision medicine using the genetic analysis of the various molecules in the diuresis can be helpful. And of course, patient-centered telehealth is very important, and that is the future. In summary, diuretic resistance in advanced heart failure is common, multifactorial, and lethal if unaddressed. Early recognition, protocolized escalation, including sequential nephron blockade and use of SGLT2 inhibitors, estrogelamide, and Vaptans in select cases are evidence-based recommendations. Device-aided telehealth-guided care shows promise in optimizing outcomes and detecting resistance earlier. A multidisciplinary patient-centered approach remains the foundation for success in managing diuretic resistance and improving quality of life for advanced heart failure patients. Thank you very much.